In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, and indeed, welcome to our clinic's weekly webinar. And as the new tagline says, clinics where health and care meet. And we trust also that we promoting healthcare services by ensuring that we bring you speakers of note, experts in their own fields and in the health industry, and they've traveled traversed the continent and the world, sharing information and experiences. And we have such a person this evening. But before we do that, just want to say thank you once more, colleagues, for joining in to our clinic's weekly webinars. We appreciate your presence, your attendance and support for the last 2.5 years or so since the lockdown 2020. And also note that these webinars are CPD accredited, and so we request that you provide us with your full details when you register, and so that we can upload your information and give it to the relevant authorities like the HPCSA, Nursing Council, the Pharmacy Council. Also, we request that you do not have to put your details on the screen, because once you register, we have your information. There's no need for you to do so. We've seen some colleagues doing so from time to time. And second is that these presentations are streamed live on YouTube. So from any time you want to go and watch the presentations, you may do so at your leisure. And so please also like us on YouTube so that you get invitations to these webinars on a weekly basis, as we present these webinars every week at 6 p.m. on a Thursday. And this evening, we're excited to present, to have a speaker of note, Dr. Tlaleng Mofokeng, who has joined us, and we're just talking to you about, travels versus the world, that she made time to be with us this evening, in spite of her busy schedule, representing the United Nations across the continent and the globe. So Dr. Tlaleng Mofokeng obtained her medical degree, MSHB, from the University of KwaZulu-Natal, Durban, and now runs a women's health clinic, DISA, in Johannesburg. At its 44th session in July 2020, the United Nations Human Rights Council appointed Dr. Mofokeng as a specialist rapporteur on the right of everyone to the enjoyment of their highest attainable standard of physical and mental health. She's a thought leader and a contributor to 5FM and Metro FM's Sexual Health radio features, Let's Talk About Sex, columnist for the Sunday Times also, and is internationally published in The Guardian, Teen Vogue, and Project Syndicate. Her areas of interest are public health policy, advocacy, global health politics, and health content production. She sits on the Global Advisory Board for the Sexual Health and Well-Being, Sex Work Education and Advocacy Task Force, SWET. Just to indicate that she's a graduate of UKZN. She's got a diploma in stomatology, a certificate in health economics and policy, and also a certificate in aesthetic medicine. So we're proud to have you joining us this evening, Dr. Tlaleng, to speak to us about health and human rights. Thank you very much for honoring the invitation and joining us here at Clinics this evening.
Hi, Doc. Thank you so much for inviting me to come on and be a part of this amazing series that you have started and maintained during COVID. It's a real pleasure to join you this evening. And we'll just go through my presentation and then we'll touch base again when I'm done, just for a bit of a discussion. Is that fine?
Thank you. All the best.
Yeah. So yes, again, good evening, colleagues. It's so great to see so many of you on this webinar. I don't know if you know this, Dr. Vila, but in my younger years, as a medical officer, I actually used to work at Lesedi clinics at the emergency unit. And I know you've done a lot of renovations and renaming and all of that. So I just wanted to say I also have some ties and some roots, to this family of clinics.
Welcome back home.
Exactly. So it is a kind of coming home of sorts. And I think it's important for me to actually share that part of my medical career, because it was at that time when I was actually trying to figure out which specialty I would go into. This is now post-internship, post-community service. And of course, many of us go through the traditional mainstream ways of specialization, but I kind of knew for myself things would be a little bit different. I've always been interested in the politics of life in general, but definitely the politics of medicine, and obviously the underlying, determinants of health, like the political, context that patients live in, but also the socioeconomic context that patients live in. And this first slide I want to share with you, it's Rosabella, can mute yourself, please. These 9 principles of medicine is something that continues even to this day to root my work in a common understanding. And I'm sharing them with you now because often when we talk about medicine, when we talk about nursing care, we are guided by professional standards and ethics. And for me, this is my first introduction into ethics as a young medical student. And of course, in the next slide, I will share with you the nursing principles as well. But one of the things, of course, just to center us so that we start from the same page in terms of our ethics, is an open-ended commitment to patients. This is something that I've carried throughout my whole career. An understanding of the context of illness. Like many of you, I still get frustrated when a patient comes in, you admit them, you give them care, and they leave well, but they come back a few weeks, a few months later, sometimes even worse than how they presented the first time, or still struggling to manage a chronic illness. And for me, it was clear that no matter how good we were within the health facility, within the health system, there was a lot more that our patients were navigating every day that we needed to understand. So this for me is actually very important about understanding the context of illness of patients. And we'll talk more a little bit later in terms of examples. And to the idea that we need to use all of the visits for preventative purposes and view the practice as a population at risk. And I think it's important, again, because medicine itself and the kinds of patients we assist still require really, really important health information, education, and communication as well. The use of a community-wide network of support, we understand this very well in terms of our referral pathways and our referral support as well. But again, thinking outside of the medical sector in terms of people who are working in social work, for example, our colleagues who are working in road and infrastructure to ensure that our patients can actually get to us. What does a community-wide network of support look like for our patients? The other one is, of course, sharing with patients of the same habitat. A little bit difficult for us when ourselves, we are migrant workers, we commute very much to work. But I think the idea is that by the same habitat, you kind of understand the social political context. You are not so far removed from your patients that their daily lives no longer have meaning, or they don't find residence with you. And this one, again, the care of patients in office, home, and hospital, very important as we think about the upcoming universal health coverage, our own NHI. But we also know globally there's a big shift and a big move towards understanding and meeting patients where they are. So it's beyond even the office, home, or hospital. It's literally everywhere where patients are. And of course, recognition of the subjective aspect of medicine. This is another important area, especially when we start going into human rights, is to understand and respect the fact that patients themselves have a subjective understanding of what's happening to their bodies. And therefore, we need to pay attention to that and respect that in order to walk the journey together with patients. And of course, then the last one is an awareness of the need to manage resources. I think this mainly comes to us who are prescribers. Sometimes we prescribe medicines that are too expensive for patients, but when you're a hospital manager or managing human resources in terms of perhaps even the nursing staff and trying to come up with a roster, how does managing of resources look like that actually supports ultimately the health and well-being of patients and that puts patients first? The Code of Ethics of Nursing, it is quite long, but I think if you look at the big thematic points, social justice as being one of the important ethical considerations, that nurses are at all times expected to act fairly and equitably, right? And I think this is really important. The idea that the Code of Ethics of Nursing starts with justice, for me, is really, really important. It's important, again, because it also says you should pursue justice. It's an active thing. It's not passive. You pursue injustice, in which means you need to understand, you need to have understood your patient's needs and understood to them what justice looks like, right? And advocate on behalf of vulnerable and disadvantaged healthcare users, and should be able to justify their decisions and actions. And I think this is really, really important. And it already hints at some of the important key principles of human rights. And many of us don't think we practice human rights every day. And the intention for this is to actually show us in different ways how we are already actually human rights practitioners, and how we can be better by now being really fully aware of how human rights integrate with the work we do. Non-maleficence is also a good one, to consciously refrain from doing harm. And this is a principle that many of us carry, even myself, through international human rights, through the multilateral system within the UN, this idea of doing no harm. It's very, very important. Beneficence, of course, is that we are required to do good. So it's one thing to refrain from causing harm, but you are also given the responsibility to actually do good and to choose the best options of care. And that's another very important thing. And often in the corporate sector, you will hear the duty of care. What is the duty of care that an employer has, for example, towards his employees? So it's this idea that no matter the circumstance, we always have to do good and choose good and be better. Veracity, of course, it's a principle that requires truthfulness and honesty. Again, this is really important when you start to think about issues around consent, right? Informed consent, whether it's for a procedure, whether it's for contraception, whether it's for a vaccination. We've come to understand, the importance of information that enables informed consent. And so truthfulness and honesty is very important for that as well. And then fidelity, entailing adherence to factual and truthful accounting and balancing. And we remember some of the best note takers are nurses. And I think this is where that comes from, this idea that you have an ethical requirement to be factual and truthful in your accounting, right? And in your reporting. Very, very important. Altruism, again, this idea of empathy, right? We have to show concern for each other, for ourselves, for our patients, and to realize that, where our actions may be to choose good, we are ethically required to choose good, that in fact a lot of these principles, draw on from one another. To do good, to want to be better for the next person, you have to have a level of empathy for that. Autonomy, very important, again, is a key principle of human right, but I think one of the things we know and understand a lot as healthcare workers, the respect for autonomy, that means self-determination, the very basic ability of humans, right, to make their own decisions and choices affecting their health. Again, this ties in very much with the idea that of veracity. We have to give people information, we have to be honest and truthful in how then they get to that position of making choices, of self-determination, of autonomy. And the last one is caring, that we are required to demonstrate the art of nurturing, by both applying professional competency and positive emotions. And again, positive emotions could even be spending time crying with your patient. I mean, I know many times I've had to do that, and as doctors, we are trained, to be strong and unwavering, but sometimes I think what our patients needed is to us to be human, so that they can see us as human, and we can meet each other at an emotional level, which the power dynamic of doctor, nurse, patient often impedes us into doing. And so I think it's really, really important just to keep the family medicine principles in mind and the ethics of nursing in mind as we go into a more human rights centered discussion, because these human rights principles had to emanate from somewhere, right? And so those are some of the key areas I think that human rights had to draw from in terms of our medical profession. Everywhere I go, I'm always advocating for nurses and doctors to be at the table. A lot of global health is very much around the hierarchy of funding and funders and who's funding what. And global health institutions themselves are not even run by doctors or nurses. It's politicians or former ministers, or people who did other postgraduate training afterwards. But the people who are us, the actual practitioners, the actual experts in the art of caregiving, are often not at the table. And so I'm always advocating for that to happen, because how will we know why the policies and the resourcing that goes into health do not yield the outcomes it requires if we are not at the table? Some of the human rights principles that guide my work and that guide the right to health as a framework, if you think about the work we do, no one can able to have economic rights, cultural rights, civil rights, social rights even, without being healthy and well. And COVID, for the first time for many people, really brought that home. Without health, without well-being, no matter what else you have nothing. And so it's important then to really think intentionally about getting the systems in health right, to get them enabling and conducive to a life of dignity for people. Because if we can do it within the health system, by respecting people's right to health, we will really go far. Because the right to health, speaks not only about the right to access a clinic or a hospital when you are sick, it also talks about the right to health and well-being and physical and mental health. It also speaks about your right to an underlying determinants of health, such as food and nutrition, such as potable water and sanitation, such as information and education around sexual and reproductive health rights. And so it's important for us to really, really think in a different way, with the understanding and the experience we have of COVID, of how our practice of medicine itself is part of being a human rights defender, because also of how many things can go wrong with people, especially within health facilities, but around their right to health. And so when you think about non-discrimination as a principle of human rights, what does this actually look like for you in clinical practice, right? And we know that non-discrimination is a very important principle in human rights, because people are discriminated, of course, we know, because of race, ethnicity, because of caste, or minority ethnic status. But we also know that migration, right, and people who are mobile often face discrimination, even people who are mobile within countries. If you come from Eastern Cape and you come to Gauteng for healthcare, and people ask you for a proof of address, it's going to be very difficult to provide a proof of address if you are a person who's mobile, who has no formal residence, who's still looking for a job. And so it's very important to also think about just mobility of humans, period, even within one country. Non-discrimination is important because we know people are discriminated because of sexual orientation or gender identity and expression. People are discriminated upon because they're from a rural area, or because, for example, they are poor, right? There's a social class that often leads to discrimination. So there are many grounds of discrimination, disability being one of them, another important one, and extremes of age. So being a child or being an elder person also can lead one to being discriminated against. And so we can see why in practice, when a patient identifies themselves with a particular disability, or that they are geographically from a different location, they are poor, they may be a lesbian woman, they may be a trans person, they may be a Black woman who doesn't speak the language, right? Never mind the sophisticated language of English and medicine, but just like whatever the local language is. And so language itself then becomes, a barrier for her. And so it's important to already, before you even start speaking to a patient, to already start thinking, what are the layers of discrimination that this person, before they even got to me, they were already experiencing, and how does that discrimination actually lead them to experiencing health or disease or some form of instability. Another important principle is one of equity. I think we understand this very well, that we need to input, we need to provide systems, we need to provide care to people that provides equitable outcomes, equality in outcomes. But with the right to health, it's also just the opportunity for favorable, equitable outcomes. And that's why underlying determinants of health is important. I mean, we know currently, recently, with the cholera outbreak in Hammanskraal, right? What those people experience is a form of inequity, right? Because cholera does not discriminate, but it's a form of inequity in that because they didn't have clean water, they didn't have sanitation that is adequate to give them an opportunity of equitable outcomes. That's why equity for them, it's an important way to analyze that situation. Participation is important because human rights, again, respect the person's or people's ability to make decisions about themselves, about their bodies, about their own health journey. So it is important for them to be part of the participation, but also part of the decision making, which requires us to have transparency, which leads me to the next principle. When patients need to be making informed decisions, they need all of the information that they can get that we can provide. And transparency is important because it enables accountability on both sides, accountability for us as healthcare workers, but accountability on the patient side. So they can also be honest where, they couldn't do particular things that they knew they needed to do for their journey or for their care. And accountability on our end to say, look, maybe we missed something when it came to an element, we prescribed insulin to someone, but we didn't bother to ask if they have a fridge or electricity that's actually in supply, that is sustainable, to actually make sure that the insulin, remains stable and good for use. So there's a lot about understanding each patient and their own particular outcomes so that we can then have, outcomes or these opportunities of outcomes for health and well-being. I've added consent, privacy, and confidentiality and dignity at the bottom there and slightly separated them because I think this for us is relevant for our clinical practice for our everyday. So those 5 principles, non-discrimination, equity, participation, transparency, and accountability, they are the core human rights principles, and how they translate into our everyday care. I've suggested some of them, but we can name a lot more than this. But, consent, privacy, confidentiality, and dignity for me covers a lot of those really hardcore human rights principles, because ultimately is how do we translate this human rights language into actual clinical care? And I think for me, that's the question I ask myself constantly. And I hope that, those examples will start to, thread a story that you can easily see in your practice every day. So the right to health is a broad concept, of course, and it can be broken down into more specific entitlements. And if you look at the broad entitlements, you can see some of the specialities of medicine and nursing start to emerge. And this again shows how linked our own understanding and practice of medicine and nursing is to human rights. Access to health-related information, education, including on sexual and reproductive health. Many of us are nurses in the family planning clinic, in the youth, adolescent and youth-friendly clinic, maternal units, and of course, maternal, child, and reproductive health is another entitlement that we have under the right to health. We have a specific entitlement to informed consent, bodily integrity, freedom from torture, ill treatment, and harmful practices. This is important because bodily integrity and freedom from torture, ill treatment, and harmful practices slightly speaks to more of the negative side. So when things go wrong, what can happen? For example, if you have, as we've had in this country, in Brazil, in India, in Southeast Asia, and many other European countries, the use of sterilization and forced or coerced sterilization on women is something that is in practice still happening. There may not be a policy on this, but in practice it happens, right? The idea that women's bodies are not respected and that political agendas can actually, play themselves onto the bodies of women. And so how you see this is that, in South Africa, for example, HIV positive women were sterilized coercively or forcefully so. And we know that forced sterilization already under the definition of torture fits the term for torture, right? And this is why that kind of language, which is quite hard, finds itself under the right to care, under the right to health, so that we understand that sometimes by acts of omission or acts of commission, we may be actually doing more harm than just either giving treatment or withholding treatment, that some of the actions or the consequences have many other meanings, right, and implications elsewhere. Harmful practice, for example, we are experiencing, and I don't know if you guys have seen this, but we experience a lot of migrating communities from environments where female genital mutilation is something that is still practiced, right? The husband stitch, when people are giving birth and, the doctors are asked to make the stitches tighter, right? There's something called the husband stitch. All of those things are happening without consent of women. They are happening and taking away their bodily integrity. They are not part of that conversation. It doesn't benefit them in any way to undergo these interventions, and yet they still happen. So it's also to understand, because when you then think of medicine as a protection of human rights, what is then your accountability mechanism? How do you protect patients from undergoing ill treatment or experiencing harmful practices under your care? The other important one is healthy, natural, and workplace environments. And I want to focus on the workplace environment, because often when, as healthcare workers, we do a lot for everyone all the time. And I always want to pause at healthy workplace environments to make one comment, in that our healthy workplace environment as healthcare workers, it's the same environment for the patient's health and well-being. And those two things are not in combat. They are not in competition with each other. And in fact, if we can advocate ourselves for our own healthy workplace, we will be doing a lot to advocate for patients' rights and a human rights and a person-centered or a human-centered approach to health and well-being. And so one thing I know, that there's always a struggle often in medicine between patients and doctors, and we end up being the face of the system, right? Yet we're not even making decisions, in terms of nutrition, in terms of, cleaning, in terms of linen, in terms of basically everything. But we end up being the face and being the recipients, right, of all of the complaints. And so when we're hearing patients complain about linen, maybe in not so much in your context, but if you think about the public service, when patients are complaining about, poor nutrition, the food is cold or it's not enough, there are many complaints that we know patients have. If we paused and think, but if you were treating a burn patient, you would surely not want them to be sleeping on dirty linen, right? If you had a patient with TB, when we know that active TB is obviously, more in people who are malnourished. So when a patient is complaining about poor food or poor nutrition in a facility of care, surely that should concern us, because we know the kinds of infectious diseases that just come from being malnourished. And so we need to have a bit of a paradigm shift where we see our own, well, at least where we see the patient's healthy healing environment as our own healthy workplace environment. And I think those two things, when we are seeing them like that, they stop being in competition with each other, and we can actually advocate for better health systems overall. And the prevention and treatment and control of diseases are something that we are very good at. This is what we go to training for: prevent, treat, and control disease. Very important. And of course, access to safe and potable water. This is now from the UN in terms of how they describe the right to health, but you can see why this is really specific and important for us as well to understand. As with all things, sexual and reproductive health rights, tend to be explicitly stated, especially because in many countries, these are still not rights. Women still need their husband's permission to get contraception. Women still need their husband's permission to get a bank card, for example. This is not, history from 50 years ago. This is still the reality for many people. So sometimes we talk about sexual and reproductive health rights linked to women's rights, linked to gender equality. because we know as well what happens with the issues of child marriage. We know what happens with the issues of abduction, and then, you know, people demanding a bride price from your family. We understand the issues of female genital mutilation, that like I explained earlier, the issues of, you know, rape of children that lead to early mothers and increased pregnancy rates. So it is important when we're talking about the right to health to also in some ways speak about the many different obstacles that keep patients right now in the majority, more than half of the world's population are women and girls. And so if our sexual and reproductive health rights are not protected, it means more than half of the world's rights are being violated. And so these obstacles are interrelated, they're entrenched, and they're operating at different systems, right? At clinical care, where, like I explained, we still have clinicians who are doing harmful things like the husband stage, or forcefully or coercively sterilizing people. But we also have issues at the level of health systems where we still don't have enough modern contraception available for women, where the only safer sex tool that's available is still the external condom, or what used to be called the male condom, which means we still have to negotiate its use and make sure it's used properly every single time, and not by us, right? By the partner that we have. So we still don't have enough tools in our hands to protect ourselves from STI, something as basic as that. And of course, in the underlying determinants of health, like I've explained, I mean, we know that young girls and older women, we still the default for household chores. So when a young girl comes from school, the boys are doing homework, they are playing, they are being children, but the girls have to fetch water, firewood, start cooking, start washing clothes, including the boys' clothes, right? And so there is an inequality there in underlying determinants of health that affect women and girls in a very different way. Of course, social, economic, and other conditions are also important to understand for all of us, our sexual and reproductive health. And that as we move forward with non-discrimination, with understanding equity, with understanding participation, we need to then start thinking about gender-sensitive and non-discriminatory sexual and reproductive health policies, especially for adolescents. I mean, we live in a country now where you open a newspaper, you read on the news, and you are hearing that the teenage pregnancy crisis, and the people who are named there are between the ages of 10 and 12, you know. There's no teenager who's 10, 11, or 12. And the question is, who's raping children? But because of the media and the way it's covered, it's now just a teenage pregnancy crisis, which by default, because it's girls involved, it becomes an issue of promiscuity, when in fact, the question is, who's raping children? But ultimately the headline is, you know, South Africa is raping children. It's not a teenage pregnancy crisis, because boys are also being raped. Boys are not getting pregnant, and no one is talking about them, because we are now just focusing on teen pregnancy. And that's just a symptom. We have a bigger problem than teen pregnancy. And we need to name the problem, be sensitive, be non-discriminatory in how we then approach and try to solve this issue. And the health policies, of course, govern every health institution. We have a constitution in the country. We have the National Health Act. We may have an NHI at some point, but even in your own institution, you have policies that guide what it is that happens in the institution. And it is important that those policies are therefore then consistent, right, with human rights standards, and recognize unequal access, of course, by adolescents, but also just generally across the board of communities that you serve, and that any unequal access is a form of discrimination, especially if you think about sexual and reproductive health rights. And I know private facilities don't often replicate the adolescent-friendly or youth-friendly model that the public sector does, but it might be a way of extending, right, yourselves to the community in the context of the kinds of problems and struggles and challenges that young people are facing. I'm gonna, just do a bit of a brief overview, not go through everything, so that we can have some time for a Q&A. But the core components of the right to health, and so thinking about all of us on this call, some of us are managers, some of us are clinicians, we are working at different spaces in the health system, even in a health facility. We should all have a common mission and a vision, so that when I am the one who's the theater nurse, I know why my job is important. If I'm the surgeon, if I'm the scrub sister, if I'm the person working in the kitchen and making sure that the patient's food is good, if I'm the quality assurance manager, all of us need to have a common vision for the facility. What is this human rights, people-centered, human-centered approach that we are going to embark on? And the triple AQ framework is really important. It's the availability, accessibility, affordability, and quality health. That framework is important because it allows us to speak, or at least sing from the same hymn book. Wherever you are placed in the institution, there's something for you under availability, accessibility, acceptability, and quality of care. And the human rights-based approach, right, to all of us provides a set of clear principles for setting and evaluating health policies and delivering the service, right? Making sure that we remove discriminatory practices and unjust power relations that are at the heart of inequitable health outcomes. And so in pursuing a rights-based approach, the health policies that we have, the strategies that we have, the programs that we have, and the delivery of care itself should be designed explicitly to improve the enjoyment of all of the right, of all people to the right to health, with the focus on those furthest left behind. And I was watching with intensity to your introductory video, and have seen all of the different ways that you name some of the things. You know, you talked about the food, you talked about the person who's cleaning and making sure the environment is healthy. You know, you spoke about the experts doing really specific and amazing surgical procedures. And I think that's really what it's about. It's about defining for yourselves what is the common mission and vision. And I think that this triple AQ framework is a good starting point, right? So availability refers to the need to have enough, sufficient quantity, right, of healthcare services, of facilities, of goods and programs for all people. Accessibility is important because often we think and we know accessibility as wheelchair. The first thing when anyone says the hospital must be accessible, everyone thinks wheelchair, which is fine. But there are other forms of accessibility, like economical accessibility. And for you, it's easy because most of your clients are on medical insurance. But even there's affordability issues because you will be, you know, seeing what scan can be done and what scan can't be done. Maybe one can be done, but without contrast because it's more expensive, or you do one after a procedure because you can't do two within a month. You know, like there are all those costs that we need to be analyzing and making sure that economically our services remain accessible to patients. Information accessibility is a big one. A lot of our patients are blind, some of them are deaf, some of them literally just a language barrier issue. So it's very important to reach all of the populations that present. And you may be as innovative as using apps on the digital tools and technology to do language translations. You may actually have humans. You may have a database to say, look, in this facility, we know of all of the 500 people who work here, we actually speak 300 languages, and list those and have the people's names. So when people come in, something as basic as just getting good information to make informed consent can change people's understanding and trust in us as well. Acceptability is good, and we don't often think about, you know, is this treatment option, is this management option acceptable to the patient? You know, we often impose our own standards, we often impose our own wishes on patients. And it's important to think about acceptability in a much more detailed and nuanced way when you are delivering care. Is this what I'm offering, what I'm suggesting, this journey we are embarking with the patient in line, firstly, with medical ethics, but also is it appropriate for the patient? And culturally, we often just use culturally appropriate, but it goes, you know, through many things. Sometimes we have patients who are religious, right? You know, in final year, in both nursing and medicine, we always get the question of the Jehovah's Witness parents, and the child needs a blood transfusion. We always get that question, all of us without fail. That's the question we all get in final year. And of course, it relates both to medical ethics, but also an intervention being appropriate for that patient. And so you know how you solve those problems, but that's just one example. And I think we ought to be thinking about it a lot more because we have such diverse population groups and we have such diverse needs, and therefore we ought to be removing the blanket approach to treatment and management to be more specific to what the patient needs. Quality is another important one. Quality speaks to the facility itself, the goods itself, so the actual beds and the medicines and all of those things, and services must be scientifically and medically approved. I think us in South Africa, you know, we are quite lucky in that we have quite robust and good medical institutions of governance as well, and training. But of course, as we move to universal health coverage, As we move to NHI, there'll be a lot more tendering, there'll be a lot more processes that may very well open us up to goods, services, facilities that are actually not scientifically and medically approved. What are the care that we need to be, approaching? So as a private facility, for example, how are you already thinking about universal health coverage? What does it mean for you, right, to maintain a particular standard of care? Safety, effectiveness, responding to individual needs and preferences and value, timely, in that we want care that's accessible, that's timeless, without lengthy, unnecessary delays. Equitable comes back again here in that we need to provide services, even where there is variation. It can't be just different because I'm Black, or I'm a woman, or I'm a lesbian woman, or I'm poor, or I come from a particular situation. So discrimination can't be part of why there are differences in outcomes, and that services must be integrated, which is something that I know that you guys do very well, in terms of not just the full range of services, but your connectivity to other healthcare workers as well. And of course, making sure that work is efficient. And so just coming back to the slide, the second point, right, is that the human rights-based approach says, I'm the expert, we are the nurses and the doctors and the healthcare workers, more broadly, allied healthcare workers. Maybe the physician has diagnosed a particular neurological condition and has referred, a patient to occupational therapy or physio, or even the dietitian, right? That's a team. In patient's mind, we are all caring for her. We are not separate people in silos. And so our approach also needs to speak to that, and that we must all understand what can the patient actually realistically do, afford, manage, and in collaboration with them, understand what they need, understand what kind of support they need to be able to then enjoy for them what is the highest attainable standard of health. It may not be for me and you, but it will be for them, what they are happy with, what they can manage, and definitely what's feasible, taking into account their life. And I just wanted to bring this slide here about human rights principles again, what they are, right? It's the idea of non-discrimination, creating opportunities conducive for equitable outcomes, the opportunity to be healthy and well, participation of patients, let it be meaningful. Transparency is important as you think about information, education, communication, that patients are enabled to make informed decisions, and that sometimes things go wrong. What are the accountability mechanisms that we have built in that allow for transparency, that allow for patients to feel that in fact there is some form of restitution and that there is some form of resolution, right, to whatever the issues are. But I think accountability as a whole, as a team, what does accountability look like between all of you as a team, right? Because we're only as strong as our weakest link. And the idea that we need to be constantly supporting, enabling, providing each other with the same kind of care and support and empathy that we provide our patients, it's very important. And of course, then some of the different ways that these principles translate in our everyday care, it's around issues of consent, privacy, confidentiality, and ultimately dignity. And that we and I see the practice of medicine as a tool to protect human rights. And this will be my final slide for now, just because I'm looking at the time and to allow some questions, and just to come back to the AAAQ framework, that as healthcare workers, no matter where you are in the service of delivery, we are key in the realization of the right to health, and that involvement, meaningful involvement of all actors, civil society, the empowerment of those who use healthcare related services. These are our patients, of course, especially those who are in vulnerable situations. And I didn't list all of this here, but you can imagine if you're a drug user, you are someone in a vulnerable situation. If you have mental health that is acutely getting worse, or that is now precipitated by an event and you are having an acute episode, you are someone in a vulnerable situation, right? And so we need to be really meaningful in how we manage and treat people and empower them. Whatever that situation is, there are still ways in which we can have patients participate in their care. And of course, I keep saying this, that we play a really crucial role. And this is a message that I take everywhere with me, that it shouldn't be a big surprise, right, to find a clinician doing human rights work. In fact, we should be leading in human rights work. And as you think about the ways in which digital technology and innovation has evolved with COVID, we ourselves as doctors and nurses and healthcare workers broadly need to be actually being taught, right? Digital health and innovation. How do we translate these core principles and skills that we have in the age of digital innovation and technology as well? And of course, with NHI and universal health coverage coming, there will be even more dependency on these tools to reach even people who cannot physically come to us. So the idea that we need to commit to ongoing change of paradigm of what we think we understand of the world and what the world is, and move away from the top-down paternalistic way of medicine, so that we actually have a real human-to-human partnership with patients, with each other, with users of the system, and that we have to think of the different ways in which how we were taught medicine was perhaps harmful in some ways, and we need to relearn and change different methods. And I think this is why these kinds of webinars are really so important, because it is part of the commitment to lifelong learning, and we need to do that for our patients. We owe it to them. And so education in the health sector is really one important element in protecting human rights. And that as modern healthcare workers, as modern doctors, nurses, allied healthcare workers, it's no longer enough to just be good clinicians. We also have to effectively communicate. We saw this with COVID. The messaging around COVID and the communication around COVID was overtaken by politicians and people who were doing misinformation. We were far too quiet for what the disaster of COVID was. And we need to reclaim that voice. We need to go back to being effective community leaders, decision makers in our own facilities, but in society in general, because we understand the different links between the different systems, and of course, ultimately to being effective managers of health systems and healthcare more broadly. So I will take a break here and hear from you, Dr. Bila, if you have any comments or questions for me. Thank you so much.
Thank you very much, Dr. Tlaleng. It looks like I've got a poor network. I hope you can hear me. You can hear me very well. Okay, thanks. Yeah, because I see the host was saying I must admit myself, because perhaps it was because when you ended, I did hear you. But it's been an exciting, it's been a wonderful topic, quite insightful, and I think a lot more to discuss. As you said that you looking at time, but I think we've got more time to discuss these issues. Yes. Some few comments that have been posted on the chat box, but I just wanted to check. You spoke about that. Maybe let me start first with when you say we must be modern healthcare workers and be good communicators. Maybe if you were to just say for this, when it comes to informed consent, sometimes patients need to understand what we are saying when you speak about, I'm going to take you in for a certain procedure. How do you advise doctors to break that down into a language that the patient? What are the ways of making sure that when you speak about informed consent, it's not just explaining in medical jargon what's going to happen? You're muted.
Sorry, I had to wait for the signal from the host.
Yeah.
So I think there's two considerations to make. Is that sometimes because of the low number of staff available just to get through the daily requirements of managing a ward or patients, right? We tend to do things in a very pressured and hurried way in medicine, period, wherever you are. And we have normalized and become accustomed to that pressured way of doing things, because there just aren't enough of us to go around to do everything that needs to be done. So I think one of the things that we actually need to demand that there be more doctors and nurses and allied healthcare workers employed generally. If you look at the ratio of nurse to doctor, nurse to population and doctor to population, we are still faring very badly behind. And that means that, Dr. Bila, when the patient comes and it's now a choice between taking 2 minutes to do informed consent or 20 minutes to go to the emergency room to look at the gunshot wound that just arrived. In terms of prioritization, it's a very difficult spot to be in, you know, and those are the real challenges that we are facing in real life. It's very rare that you have a very sterile, very euphoric environment where medicine is happening. Medicine happens in very difficult, challenging daily lives. But what I would say is that we need to update the forms that we are currently using for consent in any case, because in many of the litigation and court cases around health, many of them are around informed consent. And when you look at the actual forms we use, we are losing simply because the form is not enough. And because we don't have time, we just go through what's on the form only, and then we think that's adequate. But if you actually apply a test of informed consent and reasonable judgment, you will find that the forms we are currently using, all of us, and they are the same forms we all use, they are not enough. And that requires just a simple quality assurance officer to look at a few of those, take them through your own legal department to make sure that they cover everything they cover. And then you actually just, we need the time to speak to patients. We need the time for them to understand what, you know, just the other day, someone needed a gynecological procedure in the clinic, but what she actually had was kidney stones and edema, right? And for her, it was like, I'm wasting her time trying to explain about how her kidneys work and what kidney stones are and what all of these edema is and why the pap smear can wait, you know? So even our patients are impatient with us. They're like, I'm here for one thing and now you're taking me down this other route. So it's dynamic, it's challenging, but I think there are things we can do as a system to make it easier. And I think, of course, doing a form that, you know, okay, if I do this as a bare minimum, I'll be covered, that's fine. But it means that the form itself actually needs to be improved in order to help, you know, us and the patients. But it does take time. And sometimes you will take a week before you can take a patient to theater because they still don't understand physiologically what's happening. They don't understand the pathophysiology. They don't understand your intervention. They may be worried about, can they still do the work they can do? And maybe they are a low-skilled worker. If they are boiler maker and they now have a, you know, a scar from an exploratory lab where we say, look, we don't even know what we're going to find, but you're going to be off work for how many weeks? You can't lift heavy things. That someone is a bricklayer. You know, what does that mean for them in their life? And they may need time, you know, to contemplate what all of this means. And so informed consent is a very fascinating entry point into medicine, actually, and it unearths so much of patients' real lives in a way that I don't think any other thing in medicine does. Because when you start asking patients, why are you not consenting? They will tell you that they only earn money per fortnight, only if they show up to work, only if they stay however many hours. And it's the socioeconomic and political context of our lives and of our patients really can be quite gut-wrenching, and there is no quick fix. We need more of us in the system for all of us to share the work in an equitable manner.
Yeah. No, thanks for that. Yeah, I think it's quite an important topic. I see Dr. Zuki Sapinini says the HPCSA General Ethical Guidelines and other HPCSA documents might be helpful to respond to this question. If I go to the chat box, there's another question that I wanted to ask. Yeah, you spoke about we live in a diverse population. We're modern healthcare workers, and you know, in this time and era, we've got the LGBTQI plus community. How would you advise practitioners when they've got to be managing patients from those communities, how to approach? Because that's the issue of health and human rights, because they also have got access, or they've got a right to healthcare.
So I often say it in this way, that people who identify lesbian, gay, bisexual, transgender, they may be intersex, right? That acronym explains a lot of things, but not the same thing. Some of them speak to sexual orientation. So it's how people are having sex, who people are having sex with. Some of the acronym just speaks to gender identity, right? Am I a woman, and do I feel like I'm a woman, and am I expressing myself as a woman every day? And am I doing socially what is expected of a woman, right? Some of them speak to gender identity. What I often say is we should not cause harm. So that very first principle of do no harm is very important in this instance, because It's not that the community or that population is asking for extra things out of the system, out of anyone. They are actually saying, just don't discriminate against us because I'm lesbian or because I am gay. Do whatever you would do for any other patient. So it's the discrimination and the inequality in outcomes of their own health that's concerning. Of course, patients have different needs. I mean, and that's why, by the way, in my clinic, we don't ask patients how many people they sleep with, because it's a question that's full of judgment. They're going to give me a number. Most of the time, it's not even the right number. I'm going to look at them with shock and horror. And then what do I do with that, right? But if you know that you work and live in a diverse community where even people who are married, a man and a woman married, are still having other kinds of sexual interaction, right? What's important is to know what kind of sex are you having, so I can advise you whether you need a contraception, what kind of contraception, if you need a condom, if you need whatever other needs you have. And that is more of a useful conversation than just how many people do you sleep with, right? Because that's also full of judgment and full of stereotypes. So for me, the non-discrimination element is important. But secondly, as healthcare workers, we do need more CPD and more medical education and training. In terms of hormonal therapy, for example, many of us know contraception for family planning, and that's like the sum total of hormonal use. But hormones are being used for so many things. And because we don't want to, in some instances, expand our understanding of hormonal therapy and who can get it, we also do harm, for example, to older women who are menopausal, where because of stigma and judgment, we think older women should not be having sex, for example. So we don't even talk to them openly and positively about their health and wellness with regard to that. So a lot of people are walking around when they could be on treatment for hot flashes, for all of the other symptoms that we know, and also in the post-menopause to give them the correct information about their bone health, their brain health, breast health, for example. And so we need to realize that some of the stigma and discrimination, we may think it's targeted at one group of people because they identify in a different way, but the stigma is so deep in society in general that it actually affects everybody. It affects everybody. So it benefits all of us if we put the human at the center and make sure that the human can get whatever support and health they need. We shouldn't use medicine to judge people for the things they need. We need to use medicine to provide people with the care they need, regardless of what makes them vulnerable or what makes them different. And we need to be teaching ourselves and keeping up to date with the latest WHO protocols on gender affirming care. We need to be keeping up to date with the latest protocols on self-managed care, but also medical abortion, for example. We need to be doing much, much better to assist adolescents as they transition from childhood into adulthood, in terms of mental health as well. And mental health remains something that is still very much underserved. You know, we are not producing enough nurses, enough doctors, enough specialists. And for our country, whether you look at contemporary issues or you look at our history, mental health is severely neglected, and it ties in with so many of our issues that we currently have.
Yeah, there's a lot to learn, so we need to keep up ourselves abreast of the developments and read widely. Next question, a comment from Tokozi Lekongwana says, the right to respect and to treat with dignity in line with the traditional beliefs and ritual. How best can we as healthcare workers be assisted not to violate, more so we are from different communities and cultural traditional practices, for example, cleansing or collecting a soul when somebody dies in the ward, because they say, well, this was a shock and I did not know how best to handle it. That's not part of our curriculum, you know. And I'm sure this must have been quite a common practice even during COVID when many people are dying.
Yeah. And then the very short time, you know, that people had to even bury their loved one, never mind even access a health facility. So yeah, there's a lot we learn in the field. That's the truth. You know, there is a lot we learn in the field. And I think having a human rights perspective and principles that guide your work mean that when those challenges come, you are going to think, okay, first do no harm, but how actually in this particular instance be empathetic? How do I actively and intentionally choose to do good and to be better? And what does this look like for this family? And it may very well be doing nothing. telling your supervisor that, look, this is a situation that we have, call on your colleagues and let's not be shy as well to not say when we don't know. I think that's part of the weakness of all of us as healthcare workers. I think we are trained to believe that we should know everything. Even the way we are tested in medical school is that you know everything. If you don't, you fail, right? But like in reality, we are all in consultation. We are a community ourselves as healthcare workers, and we ought to be, being able to lean on one another for advice, and for expertise and for some reasonable action. So I'm not surprised. I knew that happened, so it hasn't caught me off guard. But I've had few things catch me off guard. The placenta issue as well. When people are in the maternity ward and someone wants their placenta, that's another ethical question. What do we do with human tissue? We have laws and acts that govern that, right? So in medicine, when you start looking at these issues, it becomes really, really fascinating to really, get to the deep depth of it, but also get to the appropriate outcome for the patient.
Yeah, there's a lot. It's quite fascinating. Many ethical questions. Here's another one from Dr. Machache. South African citizen, a mother dies unfortunately during childbirth, and the baby survives, and then the partner, who's a non-South African, not properly documented or no documents valid, and wants to, and not paid lobola for that matter, and as a result wants to registered or a rightful father because of the South African laws. You're not a citizen of this country. And then the child goes to the grandmother, and he says he was left wondering what to do, because this was clearly a violation of the rights of this father. What your comment?
Yeah, that's another one, and part of the work that I do, funny enough, is around litigation, around health. And again, South Africa, of course, recognizes, lobola as a rightful marital, state. And so that's why we even say to patients, well, not patients, but to people generally, as soon as the lobola negotiations start, you needed to have signed a prenuptial contract before the lobola. By the time you do it after lobola, it's already a post-nuptial contract. It's no longer an ANC. So without having paid lobola, without having been married in a court, I don't think they had a legal stand to say we are married. But that they are the father, you can't deny that they are the father, right? So this would be another fascinating case for me to follow up to see what was the actual resolution. I know the practice of the maternal grandmother. It's something that the courts actually lean on a lot. I don't know, maybe it's that thing that mothers are better, I don't know. But maternal grandmothers end up actually with a lot of children, while the court has to decide in terms of care of the child, sometimes foster care, but this is a fascinating one. If you are undocumented, again, how do we prove, right? Because I think that's what the main issue is that the person is undocumented, without valid documents. And so the court would probably say, what would it take to give this person valid documents so that you decrease rights violations? I think that's what it's about. You need to solve the problem so you have less and less and less of rights violations. The court can say, well, the child is safe, is fed, is healthy with a grandmother, so that's not an emergency. But if the father persists with their rights, then the court is going to say, well, what will it take? With Home Affairs currently, I don't know if it will be as easy as we would like to think. But again, very fascinating. In fact, it may end up being a Home Affairs court case rather than an actual paternity where does the child go case, because of the different obstacles of getting documents in a way to then prove what needs to be proved.
Yeah, it's quite interesting. I see there's interaction between Dr. Machache and Dr. Binini there. And I think Dr. Binini supports what is it.
Yeah.
The father is undocumented. Yeah. And so do you want to follow up this case? And maybe if we put you in contact with Dr. Machache, if you want to. Great.
That would be, I think it's the same Dr. Machache I used to refer to, actually. So yes, I can give you.
when you were you're still at the same hospital.
yes, definitely. And the court will look at the of the rights of the child. and it would look, of course, at the parental rights. And the court will always do this for the child, because the child is a minor, regardless of the status. They will always do what's in the child.
Okay, I think we have maybe 1 or 2, 3, 4 minutes or so. Anyone who's got a question, colleagues, anyone who wants to maybe go for a follow-up question, or if you've got a question, you may just raise your hand and unmute yourself if you've got a question for Dr. Mofokeng. But this has been a fascinating discussion. I think, well, a little bit on NHI, perhaps you, in terms of, I know there's another webinar taking place right now on NHI, you know, the do's and don'ts and challenges, and maybe just a comment. You did make a comment about NHI that will be, but maybe let me put this way, for those who are against NHI, would you say that then extending denial of South African citizens of their human rights to universal healthcare?
So my particular concern with the NHI, right, is that it's an administrative solution to a problem we don't have. It's still not solving the problem that we don't have enough healthcare facilities for people who need them in the country. They are not of good quality. We don't have enough healthcare workers. Even if they built those facilities tomorrow, we don't have enough people to run them, right? And that in fact, the reasons why people present late for cancer screening or treatment is that, for example, now I'm from Kwakwa, if you need anything done, you need to sleep at Manapo Hospital, sometimes 2 nights, to try get a space in the taxi to take you to Bloemfontein, which is 3.5 hours away, you know? So we can't, there are just basic things we need to know we can do well and monitor and evaluate and know that we've done them so well that the learnings from those things inform what NHI should be. Right now, I'm not sure that we have implemented, monitored, and evaluated good systems systematically across the board to inform an NHI in the shape that we need for us right now to respond to the needs that we need. If it's an administrative and very cumbersome in administration, it will lead to even less access, because you are now going to deal with administrative bottlenecks, which are now artificially made, right? As opposed to actually ensuring access, equitable access to everyone, everywhere where they need it. And I'm not sure that NHI is going to do that. And unfortunately, we know that the state has no internal capacity to even run the state itself. So who's going to end up running NHI? It's the very private sector insurance companies who are currently running the private sector. So now we are by default going to put ourselves in a situation out of desperation, going to lean on the very private sector to come administer an NHI that in its form and shape is ill-designed for what we need as a country. That's all I'll say.
Yeah, no, thanks. I think it can't be much. I think it's a valid comment, and which you've made, and I think I haven't had anybody making a comment in approaching it that way, and thanks for that approach that you've just made, and it does make sense. Maybe we should just take a party shot by this comment. Thank you so much for highlighting that as health workers, we are a community, because if we can take this ethos, thus we can reduce the litigation in some doctors act as yes or no and attitude, and with consultation as opposed to consult with other healthcare workers. I think that's my little bit of Zulu. I can know that we left out to the end there. But I think, thank you very much, Dr. Tlaleng Mofokeng, for this enlightening discussion. And I think it does come across that it's you're traveling both in Africa and also across the world. You've seen different healthcare systems, what works and what doesn't work. And I trust that with your input and people like you, we can learn a lot for our own country to improve healthcare delivery services, both in the public sector and the public sector. And once more, thank you very much for availing yourself to talk to us this evening.
Thank you so much.
Yeah, and I also want to thank, I also want Dr. Pinins, I also want to encourage us to do medical law courses offered by UWC. I think, she's advocating for that, Dr. Zuki. And also want to thank the colleagues who we've logged in this evening, and so quite a number of you have joined us this evening to listen to Dr. Tlaleng Mofokeng talking to us, and we appreciate your support all along, and we trust that you shall also join us again next week as we continue with our webinars, and we're looking at the other disciplines. I think we'll be getting more colleagues from the pathologists, the chemical pathologists, microbiologists, and also the radiologists will be talking to us about approaches to medicine. Also to thank Kamo from Marketing Division, who's always here with me as we make sure that we impart knowledge on behalf of Clinics Health Group, and getting colleagues from different fields, from both medical, nursing, and other allied health professionals. And we thank you very much, Kamo, and the team that's working with you from the marketing team to making sure that we get this webinars going on. And we'll continue again next week. And we hope we had a good time with us this evening. And please keep warm and have a good evening. Thank you very much.